You're tuned in to RX Radio.
When's the last time you had back pain that like you didn't understand like the magnitude and severity of it? Obviously, like you're a professional, you study this stuff, you've dedicated your life to it, but like, I don't know. My back hurts, I think, as much as anyone else, but is also as much as everything else. Like it's not like my pain experience on a day-to-day basis is not encompassing of my back only. My back is a part of that, but right. it doesn't jump off the radar. Like how much of the pain that you see in practice or that you hear about on the internet and DMs and stuff, do you think is like a cognitive hypersensitivity around the potential unknown ramifications of the back compared to like, I don't know, a shoulder or a knee or an ankle?
Yeah, I think it's less understood than other parts of the body, as much as other parts of the body are not very well understood by the general population. I think when it comes to back pain, people think that it's more serious because it's so limiting. Like if I have right shoulder pain, I can get through my day decently well without using my right shoulder. I cannot get through my day at all without using my low back. So I think it's very prominent, very prevalent when people feel it, when they have discomfort, or it's very limiting when they have low back pain. So I think maybe that's why it's something that is, maybe taken a little bit more seriously or not as well understood because so many things cause symptoms when people do have low back pain.
Yeah, I think paradoxically, and because I think there's another side of this coin. So maybe there's some justification around the cognitive hypersensitivity around low back pain due to its omnipotence and omnipresence. That it's like, it's hard to do anything when your back hurts. But I think one of the other issues, if there is a slightly like kind of a fear of the unknown, it's like, I don't really know about the structures. I don't really know, what it's supposed to do when it's not hurting. Like, it's when you don't have back pain, your back, you don't pay any attention to it. And it's only until it's painful, you're like, oh fuck. And then, so there's a lot of unknown around, obviously, like anatomy and neuromuscular physiology, and there's a lot to it. The spinal cord, the central and peripheral nervous system. But how much of the issue do you think is on the other side of the coin of people's way of addressing all of the other maladies, shoulder, knee, hip, and so on, being rest? Like, I think that's the other side of the coin. It's like, all right, I don't understand this thing, and when it hurts, it gets in my head, in part because it's ever present and there's nothing I can do. There's usually, with knees and hips and shoulders. In very rare cases, you got to fuck yourself up pretty bad to be like laying down and your shoulder still hurt, right? Like that's a bullet wound is what that is, right? But shy of like some sort of rotator cuff, whatever, orthopedic diagnosis you're going to get, you can lay down and your back can still hurt. Like it can be unrelenting pain. But I think one of the issues is that the application or the remedy for every other physical malady that people have, right? Shoulder, knee, ankle, and so on, is rest, is finding those positions where it doesn't hurt and kind of ignoring it, and then hoping that the natural history of pain, and we'll talk a little bit today about natural history, runs its course and the pain begins to subside, or you begin to normalize it and desensitize to it, whatever. So I think those two things together, the unknown nature of the pain, usually a lot of times, and not always, but like I would use the word idiopathic, which means it happens and I have no fucking idea how it happened. I don't know. I just woke up, or you've done something, you're doing something that you've done a million times before, and then for some reason today was the day that it was the straw that broke the camel's back, you being the camel. So it's like, I think there's two sides. One is the unknown aspect of, the structure, function, relationships, but the other is we're seeking the same level of palliative care that we seek in everything else. And I think that's where, look, you don't need to have a background in spinal anatomy to be able to navigate your way out of low back pain. I think what you actually need to do is establish a better heuristic to get yourself out of pain everywhere else first. And then learn to apply that heuristic to the spine. Because I think they're very, very similar. When you're dealing with shoulders, when you're dealing with knees, when you're dealing with hips, a lot of times dealing with it means avoiding it, right? Like someone comes into your office, they have shoulder pain. I've been avoiding bench for like a few months now. And it's like, okay, that's actually part of your problem when you hit the wall with low back pain and it creeps up out of nowhere and the grim reap just kind of gets you in the low. It's like your model is broken. Your model that fixes everything else is actually one of the reasons that your low back pain becomes so daunting. Because if you had a better model to fix everything else, you'd actually have a way better model without understanding the structure-function relationship with the low back to fix your low back.
Yeah, I absolutely agree with that. I think people, they fall short in their understanding of how to actually intervene when they're in pain on the whole. And the low back isn't any different than that. But I think the way that we could think of this, the way we could frame this is a little bit different, because there's another layer to low back pain that I kind of thought was bullshit until I experienced it very recently. But, and I don't, in my experience at least, I don't hear this very often with other regions of the body. But there's a psychosomatic component. And like stress and being in stressful situations, not dealing with that well, like sleep, under recovering, things like that. I understand that if you're currently in pain, under recovering, overstressing, poor stress management, it will make the pain that you're feeling maybe more prominent or worse. But psychosomatic back pain was something I really didn't understand until I felt it for the first time. And I'm like, oh, maybe this is real. Maybe this isn't bullshit.
Maybe everyone's not a huge pussy. Yikes. I have some apologies to make.
I did not say that. I think everyone is still a huge pussy. You're still a huge pussy. But it just means that you're not managing your stress. And like I'll tell you, the first time that I felt this, it was a stressful weekend. I was traveling. Long story short, I had to put my dog down that weekend. A stressful fucking weekend. I had to fly home. Paid a bunch of money for a one-way flight that I shouldn't have had to pay. Saw my dog. Understood that was it. I had to put him down. Put him down. The one thing I know in my life that helps me manage stress is going to the gym. So I went to the gym, and I wanted to send it on a leg day, send it on some back squats. I put 70 kilos on the bar, and I had crippling back pain. Like, down both my legs. The most insane feeling I've ever had. And I'm like, this is that thing that people talk about. So I think that there is a component to back pain that is almost perpetuated by the stress that back pain can cause. Is what I'm kind of getting at with this, is that there could be that psychosomatic, that moment where the stress that you're experiencing is actually making the symptoms that you're having worse, and it could actually be the symptoms that you're having that's creating that stress. And I think that's something that's a little bit more unique to low back pain than it is to maybe a shoulder or a knee or a hip or something of that sort. So I think looking at how we're diagnosing and treating and intervening with low back pain, we need to kind of break it into three categories and see how much of each of these it is and if there is overlap between the three. There's the structural issues. There's things like disc issues, ligament. There's actual muscle tears, things like that. There's functional issues that are more movement pattern based, or even like I'd put like muscle spasm, movement pattern bias, where we just have asymmetrical movement that's not necessarily caused by structural abnormalities. And then there's that third bucket that would be the psychosomatic. So I think before we can really intervene, we need to understand how each of these three causes of low back pain is interplaying with the actual symptoms that are present. And that starts with understanding the symptoms, like you know, the OMP3, QRS, all that shit. Like, so if you didn't go to school, which wasn't myself, like understanding how these symptoms present. So what is the onset? What is the mechanism? When did this start? How did it start? What was there an injury? Is it something that crept in over time? Did you just wake up this way? What else is going on in that person's life? Are they, are they in a high stress period of life? Did they just change training styles? Are they in a new split? Are they prepping for a competition? Are they in a caloric deficit? Understanding all the contributing factors that could be playing a part in physical and psychological stress for that person, and if there were any injuries around this. And you can start to make some inferences based off of that and start to understand, okay, this seems like there was no cause of a structural injury. They didn't hurt their low back during a back squat. They woke up with this pain. So, okay, maybe it's more muscle spasm, maybe it's more psychosomatic than it is structural. And starting to understand the root cause of why they're having this pain will direct the focus as you get towards intervention. And then two of the most valuable things, no matter what types of pain someone's feeling, for me to understand are what makes it feel better, what makes it feel worse. Things that are palliative, things that are going to either not affect or increase decrease the sensations of pain that you're having. So what are the things that are going to make this feel better? We need to understand those things, and the more we can understand the mechanism in which those are causing it to feel better, that gives us more insight towards the treatment. And then the things that are going to provoke pain, that are going to make it feel worse. And if we can do the same and understand the mechanism in which this might be causing it to feel worse, that gives us more insight into what the original injury might be, and also gives us insight into things that we're probably going to want to avoid in the rehab process or use later on in the rehab process in kind of a reintroduction phase to see how well they're healing or the rate at which they're progressing. And I think having that understanding around not just the fact that they're having pain, but understanding the origin of the pain and is it structural, is it functional, or is this a stress management issue? I think that gives you a really good direction in the route that you need to take when it comes to intervening with that pain.
Yeah, I think there's two situations here. You're a practitioner, you're a coach, you're a trainer listening to this, and you yourself are experiencing pain, and then you're a coach, clinician, practitioner, and you're dealing with someone with pain. Because like the more you know, you hope, the less daunting this becomes, and like the longer you just live, the more often it happens, and you live through it, and you're like, all right, well, I didn't end up dead from last time, so I'm not probably gonna end up dead from this one. Now, when this is a novel experience, like when you're dealing with someone who has this issue, and I like that you honed in on palliative and provocative, because those two components of a history taking, when it comes to like the communication of the action steps to get people out of pain, this is where you're treating more than just the physical. This is where an understanding of the physical, when you're looking to remedy this issue with another person, so this person has low back pain, they're coming to you, your understanding of, or how you interpret rather, their provocative and palliative movements. So let's just say palliative, what makes it feel better? What's common? Walking around, it feels worse when I sit. So provocative would be sitting, palliative would be walking around. Foam rolling makes it feel better, and ice and heat make it feel better. Okay, great. The more you can recognize the potential physical underpinnings of both palliative and provocative and communicate like things from both buckets, like things being like, well, okay, so if it hurts going downstairs, we're going to avoid X, Y, and Z because there's similar loading patterns to going downstairs. And on the flip side of that, the more you can look at something and be like, well, stretching my hip flexor makes it feel better. Great. We're going to do this, that, and the third that are very similar to a hip flexor stretch that you like. What you're actually doing, or not actually doing, one of the things you're doing, because the primary thing in your mind that you're doing when you're communicating this with your client or patient is you're trying to establish a technical framework for how it is that you are going to address this, right? Like, okay, what are these like things? We're going to avoid the painful positions, and we're going to double down on things that are palliative. Like, that's like almost so simple it doesn't even have to be said. But I think it has to be said because what you're again, not what you're actually doing, but one of the other things that you're doing while you're communicating this process to your client of clearly being able to, okay, this makes it feel bad. We're going to avoid that. That's already a fucking cold start. Well done. That simple phrase, well done, because now we're starting to deal, this explanation of the technical is actually the beginning of palliating on the tactical side. When you're explaining your understanding of their experience of pain, you're starting to actually address the psychosomatic portion of it, right? And that's key. A lot of people just kind of internalize it. They go, okay, got it. We're going to do this. But it's like, no. The why is so important because the why starts to treat the psychosomatic. The why, the be, and this is like a fairly deep concept because when you identify that you understand what causes them pain and what makes them feel better, and you start to lay out multiple options of things they're going to avoid, and then multiple options of things that are going to improve their symptoms, what you're actually doing is you're improving motivation. And that's key, right? Because motivation is going to drive compliance, and to quote our friend Stan Efferding, compliance is the science, right? Motivation is literally the push and pull, the carrot and the stick. So while communicating or understanding this is obviously useful as best we can understand it, right? Like, okay, maybe the mechanism was this. There's an extension intolerance, there's a rotation intolerance. We're going to avoid all this. The act of parroting that back to your person and being like, okay, I hear what you're saying. This is bothersome. Likely, if this is bothersome, this and this and this and this and this will also be bothersome. Right. This feels good. Likely, this and this and this and this will also feel good based off of this mechanism. And this is an intrinsic process that should be extrinsic in the sense that this is usually how, like whether you know it or not, or you're deliberate with it or not, this is kind of how you address things. Like you try and figure out patterns and then you go off it. The key is the communication part. Because what that does when you verbalize and you go, yo, based off of this, I think we're going to do this and not do this and this, all of a sudden, you've just increased their motivation. You've recognized the stick and you've made it smaller. You're going to take away, look, most people like, I don't know. I don't even know how it happened. I just turned around and it's down. Okay, I do, or I think I do, maybe, hope I do. I'm going to tell you that I do. These things are like this other thing and we're going to avoid. The landscape just becomes so much less daunting because there is a trepidation because of the omnipotence and omnipresence of back pain. And then on the flip side of that, we are going to do this, this, and this. Every line item on that list is improving their motivation. It's understanding that there is less things I need to run away from, and you're taking care of that. And it allows me to focus on the things we're running towards. Those are literally the tenets of motivation. So as much as the OMP3, and I just, frankly, it's the palliative and provocative, as you said, are kind of like the more important ones. It's the communication of those elements that actually start to treat more than just the physical element of the thing you're trying to quote unquote treat. It actually starts to dive into the other bucket of the somatosensory. How do you like that?
Sorry, I lost you on the end of that. A little bit of a lag. But yeah, I absolutely agree with what you're saying. And the communication part of things, I think that there's a point where someone that wants an answer will just follow someone that says they have an answer, right? And it's a very real part of this solution. So if you're someone that is confident that you can get someone out of back pain, I think communicating that and letting them know that there is an answer. There's something that's going to help them, and you can help them through that process. I think that's the value in this, more so than what you actually do. Letting them know, communicating that there's a way out of this, and of course doing so in a genuine way. Like, don't just fucking lie to clients. But a lot of times, so if I'm looking at someone that has a herniated disc and they have kind of something wrong in all three of those buckets that I mentioned earlier. There's something structurally wrong, it's inhibiting function, and this is causing them a lot of stress, so they're having psychosomatic pain as well. That's okay, we have a lot of shit going on, but we also have a lot of shit that we can clean up and a lot of shit that we can make a difference in how they're feeling. So with that, you may not have the answer to solve their problems right away, but you might understand that, okay, this is an acute injury, and we probably have about 6 weeks where we just need to keep them moving and do so in a way that's not going to make their symptoms worse. And that's actually the first part of the healing process. So if you have confidence that you can take someone through that and you can set realistic expectations around that, is that, hey, the first 6 weeks are going to be tough, but here's the plan, here's what we're going to do. And if we keep track on this, we'll keep tabs on it, I guarantee you that 6 weeks from now, you're going to be feeling 50, 60, 70% better, because honestly, they probably will, as long as they don't get re-injured. So being able to understand the process at which someone's going to go through with the injury that you're dealing with, and then confidently communicating that, okay, this is the way out of this. Like, I think a big part of that is, as you kind of started the podcast, not knowing. People don't have an understanding of what's going on when they have low back pain. I remember graduating chiropractic school and not really knowing what to do with someone with a disc herniation. Like, I had no fucking idea. Yeah. Thanks to that diploma on the wall, I had no shit. So that means just someone that didn't go and get a doctorate in spine, they have no fucking clue what they should be doing. Dumbass. Why the fuck would someone get a doctorate in spine?
Retarded. We're so retarded. God. We're like actually retarded. I'll spare anyone the trouble of being like, you guys are fucking chiropractors. I was like, yeah, dog. I'm right there with you. This is so dumb. Giant so fucking receipt dumb. On the wall.
God damn it. Just fucking kill me. But anyways.
Me first.
All right, I digress. I needed that.
It got real.
Thank you.
Real.
I'm going to cry. I'm just going to cry.
He didn't leave a note. He left a podcast episode.
He killed himself with his diploma on air.
Oh, my God.
Anyways.
You ended up with doctorate in spine.
Doctorate in spine. Someone that doesn't have a doctorate in spine and doesn't regret their life decisions. They have no idea what they're dealing with in terms of the healing process of a disc herniation. Right? And honestly, as a personal trainer, you may not either. But you've probably dealt with it before, either on yourself or with other clients, whether you know it or not. So it really does come back to understanding the symptoms, and you don't have to have this level of understanding around it to make a difference. You can literally say to someone like, hey, we're just going to do the things that make it feel better, and for the next 4 to 6 weeks, every single session, I want you to walk out of here feeling better than when you walked in, and that's going to be our goal. All right, so we're going to figure out the things that allow you to do that, and they could be like super low tier things. It could be sitting on a foam roller. It could be breath work. It could be psoas work. It could be side planks and bird dogs and curl-ups. It could be the most basic stuff. But if you can get them to move and you can get them to understand that there's positions that if they create stability here, it's going to take that discomfort away from the low back, and understanding the bounds on the things that are more tolerated and the things that are less tolerated. That helps. That awareness helps. So it doesn't necessarily have to be this deep understanding of what a disc herniation is or the actual mechanism or what caused the pain. But if you can understand and interpret what they're telling you, which is not that hard if you listen, just listen and ask the right questions, then they basically tell you what they need to be doing and what they shouldn't be doing. And the thing that I've noticed is a lot of times people don't really understand that's what they're doing. Like, people will tell you these are the things that make it feel better, these are the things that make it worse, but they need someone else to, like you said, parrot that back to them and tell them, like, okay, well, we're not going to do this, this, and this, but we are going to do this, this, and this. And if you make it, they probably have some level of unconscious awareness, but if you make it a very conscious level of awareness around the things that they need to be doing, and then point out when they're in those positions, when they're not in those positions, and start to really allow them to have that awareness around this, set realistic expectations along the lines with the process of what it's going to be, that's going to be the stuff that gets them from being in debilitating back pain to being in moderate back pain. And then once you're there, then you can start to make those gradations back to things that look like normal training, getting them to resist movement through the core, understand how to stabilize their lumbar spine, the things that look more like what a personal trainer should be doing or rehab should look like. That's how you gain the trust of clients, and that's how you get people to feel better. And it doesn't require much knowledge. It's mostly around communication, understanding what they're feeling and asking the right questions around what they're feeling.
Yeah, I think it's people really, when pain is involved, people love to look at the science. And I can tell you, the science around low back pain, really bad. Really bad. There is an author, he's an MD named Norton Hadler. I think I've read most of his books. Stabbed in the Back is one. What else? Stabbed in the Back is this popular one. Healing Back Pain is another. Now, he takes a very Now, part of his book, he takes a very scientific stance, but he does so in a way of almost like a meta appraisal of low back pain research. And he's like, yeah, like it's not great. Like it's really kind of a crapshoot. It borderline seems inevitable by frequency, and from an intervention standpoint, we're not really sure in research what actually works. His book's a bit older. I'm not sure if his stance has changed. I read it and I thought it was like, okay, this is a very honest critique of the current state of the science. However, you bring up something interesting. Sometimes it's about just knowing the scientific process, rather than knowing the science. Because in absence of prevailing science, as far as like, hey, the research doesn't really come to a consensus on this, that's not like kind of pessimistic or borderline just like random. So, but if you understand like the scientific method of like, okay, I have a hypothesis, I have a subject, there are methods, there are interventions, there is data collection, there's interpretation, and then there's a discussion. That's probably, knowing that will probably lead you as far as knowing any of the research studies. So kind of what you said, it's like test, retest.
Yeah.
You have a hypothesis, you have a subject, right? You have methods, you intervene, you have a discussion, and then you run it back, right? Like, I think people are, and the only caveat with that is that just takes some honesty as far as managing expectations. Like, this is what we are going to try. And it takes a little bit of integrity to go, it might not actually work, but we have other options, right? Like I will go as far, depending on the severity of the pain, to be like, look, my scope is limited to here. However, I know this guy at the end of this scope, and at the end of his scope, there's this guy, and at the end of that scope, there's this guy. Hope is a big part of getting people out of this, right? Like positive outcomes. Now, if we want to talk about research, that's the stuff that actually is shown. Like if you maintain a positive outlook on your injury, those people heal faster. And you see that from, and this is like far extends the realm of low back pain. You start to see that in like cancer research. Like you start to see that with like real fucking problems. Like not to dismiss anyone with low back pain, but you see the power of optimism expressed in research, laying out like, okay, I'm going to be realistic with you from a musculoskeletal perspective, from a movement perspective. We can actually do more than most people think. We just need to change your heuristic on the way you actually address injuries across the board. We're going to make special considerations around the spine. We're going to avoid this. We're going to do this. We're going to test. We're going to retest. But if this does not work, I'm going to send you to fucking this guy. And this guy is a physical therapist, or he's an orthopedist, or he's a regenerative medicine specialist. And if that doesn't work, then we can do this, and then we can do this, right? So I think keeping optimism, and most people, they look at that, they look at the inverse of that. They look at the going to someone and being like, I don't really know. I don't really know if this is going to work. And if it doesn't work, I'm going to ship you off to someone else. They look at that as a bad thing. They look at that as instilling doubt into your patient. They look at that as instilling doubt and maybe instilling pessimism. Like, oh, fuck, like, what does this Jerry know? He knows enough to know that he doesn't know everything, which I think most people, and in my experience, 100% of people recognize that. And when I haven't been able to help them, I'm very quick to be like, okay, this isn't working. Off you go to the next plan. It's almost like that scene in the Joker movie where he like walks out of the hospital and it blows up behind him, and he explains to like the Two-Face guy, like, hey, look, if no one panics if things go according to plan. So if you're dealing with cases that are more complicated, and even some cases if they're not, if you're dealing with someone who might be more complicated, let's say, it doesn't necessarily have to be the case, you want to lay out the plan to an infinite number of solutions. Because that way, when stuff goes wrong, and things will go wrong, it's all part of the plan, right? And that way they don't freak the fuck out. That's part of managing expectations. But it's on you to know where your scope ends. Because a lot of people, what I see is they have, sure, probably an effective range within their scope. They don't have the best exclusion criteria to know whether or not someone needs to start working with them or start working with someone else if they don't have a super broad scope. And they harbor and foster this person for too long, and they need to come up with all the solutions because they haven't on the onset gone, look, I don't know everything. I know this little chunk of the wavelength over here. It's adjacent to this chunk of this wavelength. That's adjacent to this chunk of this wavelength. and we're going to find the right frequency to get you balanced. And it might not be with me, it might not be with him. So if you can lay that out on the onset, and again, it's kind of coming back to your overarching point of communication, we're good. We'll find a solution. Even if the solution isn't even invented yet. Like if we just keep the optimism, keep making, measurable subjective and objective progress, maybe AI will invent a solution in a few years, and this person doesn't lose hope. Because there's nothing, have you ever seen the movie Scent of a Woman with Al Pacino?
Nope.
All time. He has a scene. Basically, he says there's no. I'll spare you the long intro and setup for the line, but he's like a blind colonel in the military, and he's kind of appearing in this court on behalf of this kid who's like on trial for not snitching on one of his classmates. That's the short version, and he uses the phrase, "There's no prosthetic for an amputated spirit," and I was like, "Oh fuck, Pacino, so good. That's what you need to protect." Okay, yeah, that didn't work. Back to the drawing board. We got this. That's on you. That's the burden you have to carry.
Yeah, I like that a lot. And I think that having confidence in what you don't know, it builds better buy-in for the confidence you have in what you do know. And that's the way that I practice to a T, because I'm very certain at the problems I can solve, and I'm very communicative about the problems I don't know if I can solve. And then I'm very confident in the problems I cannot solve. So I think that when I'm having that conversation with the client, and I could show them that range of like, okay, this is what I do. I can probably do this, but I'm not 100% sure. And these are the things that I'm not going to touch. But there are people that we can send you to if it comes to that. But also, in the interest of preserving hope, like you said, I think the biggest thing that you can do in a situation like this, where probably anyone who's listening to this podcast, whether you're a therapist, a trainer, coach, you probably have the tools to help someone through low back pain, whether you know it or not. But the best thing that you can do to preserve hope, under promise, over deliver, continuously, right?
Write that down, kids.
Right? Always. And that's something that I do with every single client, no matter how confident I am with the situation. I've never worked with that person for that thing before, unless I have. But every time it's a new experience with this case, and as confident as I am with what I'm seeing and how I've solved that problem before, it's still a new situation. So I err on the side of caution, and I'm not going to say with blind confidence that this is what's going to happen. What I'll typically do, and the way that I approach this sort of thing, whether it's training, whether it's a chiropractic client, or it's someone I'm just consulting on this sort of stuff, it's exactly what you said. It's the scientific method. It's test and retest. But what I'll do is I'll have a conversation with them. I'll understand as much as I can through history, through subjective interpretation of what's going on, so them telling me what's going on. I'll do some sort of objective assessment. I'll see what I can observe with them moving, or me moving them if it's more in the clinic, and then I'll have some sort of intervention. I'll put together something in my mind, in my brain, that should fix the issue that I predict this to be. And that's it. Is I see how this works before I give them any sort of prognosis. And I'll tell them that. It's not like this is a secret. It's like, this is what I want to do. I want to go through. I want to learn as much as I can. I want to go through an assessment. And I want to do some sort of intervention. And we'll see. After that intervention, I'll tell you my opinion on what's going on and what I think you can expect from it. And you have things that are going to, typically what that is, I'll have, if I have a diagnosis of there could be one or the other, a disc herniation, or maybe it's just reactive muscle spasm in the low back. Maybe that's my differential. I'm somewhere in between these two diagnoses. So I'm going to have things that I'm going to put in that if this is more muscular, this is going to help. If this is more disc-oriented or structure-oriented, this may have no effect or make it worse. And as I go through, I'm gonna have these things, these interventions that are going to help make me more certain of my diagnosis. And that's the testing process. That's the intervention is informing the treatment. is what I'm doing there. So I get through maybe 4 exercises or 4 things that I'm going to do with this person. And I now have each of these 4 things is either going to confirm or deny one of my 2 prospective diagnoses. So then by the time I get through this, they're feeling better or they're feeling worse. Typically they're feeling better because I'm not going to continue to do things that make them feel worse. But even if there are things in that exercise selection that make them feel worse, that's information for me that, okay, these are in the provocative category. Okay, if flexion and rotation of the lumbar spine causes radicular pain down their leg, that's going to be a really strong correlation to this being more of a disc issue than a musculoskeletal issue or a muscular issue. So I'm just compiling this information, and then at the end of that, I can now have a more informed conversation with them, is that this is what I predicted it was going to be. This is how it reacted to X, Y, and Z, and this is now what I think. And because of that, this is the prognosis that I think you can expect. And that's a very realistic way to go about this, where you're informing the process as you go. And there should always be a conversation of, okay, I've seen a disc herniation of this magnitude before, or maybe you haven't, but you did some research, and you can expect that for the next 6 to 8 weeks, you're going to have these systems that are going to be present. I would avoid this, this, and this because these are the things that we already know will make it worse. And I would encourage this, this, and this because these are things that we already know will make it better. And if you can do that and you can manage expectations in that way and stretch out the timelines, say that they're probably going to be in pain 8 to 12 weeks, who knows? But if you can get them to feel better in 4 weeks, just by having that informed process, managing expectations, being confident in the things that you do know, being confident in things that you don't know, then that's going to give them hope. It's going to give them buy-in, and they're going to be more receptive to the process. And even if it's not going according to plan, they have that trust, they have that buy-in that you're going to tell them that, okay, this isn't going how I thought it was going to go. Let's pivot, let's change, or I'm going to send you to this person because I need a second opinion.
Yeah, what I like about that is it's, you use the word realistic, but it's actually, it's that, and it's also scientific. Because if you think about the scientific analogy of a single intervention being tantamount to a single study, what you've done there, and like, what a clinician would call, or what you would call, obviously, like a cluster of studies or a cluster of assessments or a cluster of orthopedic evaluations. So like, for the Chiro students out there, sorry, you're in too deep. You got to finish this shit. But like, you'll get taught clusters. And I think trainers should also have clusters of like, these things are more alike than different, and these things are different in their own way, but more alike. And then if you start to see results, positive or negative, coming out of these clusters of interventions, it helps form a more robust decision rather than just relying on one data point. So in research, that would be the equivalent of like a meta-analysis. We do study after study after study after study. You do intervention after intervention after intervention after intervention, and then the collective, or the aggregate of the results of those interventions, just like the aggregate of the results of those studies, form a consensus. They form a scientific consensus. We call it, a meta-analysis. A meta-analysis would kind of be an overlay of all the research on a particular topic and the consensus out of that. So when you build these clusters, you're actually still, again, you don't have to, and this sounds bad because people love leaning on the science, and it's usually people who don't have as much experience, which like, hey, use that to inform your interventions. But over a certain time, the thing that informs your interventions the most is results, right? That's the thing. Like I know a lot of people that will look right past someone who's telling them that a particular intervention that they've derived from science is provocative, and they go, well, this is what the science says. It's like, well, what about the person, right? Because research-based and evidence-based are two different things. Evidence is a much larger, more clear picture than just research. But you can formulate, just like in research being hierarchical from case study up to randomized double-blind control, and then in randomized control study into a meta-analysis, there is hierarchy of evidence on the individual level as well. And you want to, just like at the scientific level, you want to have the highest quality of information through that vector, right? So if you're going to be going through, okay, I need to really play the man on this one. Like, look, sometimes you deal with compounding cases where people have multiple injuries, which actually nullify your ability to stick to the data. Like comorbidities physically are pretty common, especially when you're dealing with sports. I'd like to do this, but he can't because his ACL or because his fucking big toe or because whatever. So it's like at a certain point, you got to step out of the research world, take a little bit of ownership, but don't lose the essence of science. Use it and understand how can I now, dealing with one part of evidence or two, if you have some professional experience, playing the man, playing the patient values, using your professional experience, dispensing with no research that allows you to really, coincide these physical comorbidities. I'm dealing with like a really unique case, which the better you get at it, the more unique cases you're going to get, because like I've went to everyone else, and it's like, okay, now I'm going to actually just use the rigor of the scientific method on this person. I can't use the outcomes of the scientific method because, sometimes you're dealing with outliers. And sometimes those outliers don't have to be, comorbidities of physical pathology, meaning they have like multiple injuries that would nullify interventions from particular research. Sometimes you're just dealing with people who are really, really freaky strong or big or fast or a combination. And it's like, I don't know if I can use the stuff over here, but I can always use the framework. And I think one of the things, like to kind of double down on your point, is like putting these clusters together starts to build the quality of the data, albeit from one of the three pillars of evidence, the interaction you're having and the results you're getting with your patient, client, athlete, whatever your professional designation is. And that is something that you can start to weight more heavily. So I know a lot of people, they go, they do an active straight leg raise. And it's like, disc herniation, SI joint sprain. And it's like, hold on, man. Like that's the weight of an individual case study, right? It's like that doesn't hold a lot of weight in the scientific world. We still can take that scientific framework, bring it over to the anecdotal world, and we start to validate multiple data points, either sensitive or specific, ruling things in and ruling things out, to start to build the quality of the data we're collecting in the anecdotal world. And the nice part is we are so proximal to the objective outcome of pain reduction that our results, whether good or bad, should be immediate, which is also one of the benefits of being able to operate in that world. And it's where I think the anecdotal world and the science world, albeit ever clashing when people live on one side of the aisle or the other, I think the scientific method is the thing that bridges the gap, and the anecdotal world needs to adhere to that method and understand that adherence to the method is going to improve the quality of the evidence that you have, and it's going to allow you to make better decisions.
Love it. Yeah, I think an important thing to mention along the lines of making better decisions and interpreting information that's already out there, there's a lot of systems out there around low back pain. There's a lot of frameworks that have been set that don't have a robust enough exclusion criteria. Is a pretty dumb way to say it, but true. And I think that there's a lot of people that look for solutions, and they're sold these solutions, maybe out of ignorance, maybe out of lack of experience, whatever it is. But there's a lot of things out there that will tell you that this is what fixes low back pain. And they could be right a lot of the time, but they could also be wrong a lot of the time, because unless you're understanding which situations, not necessarily which situations this applies to, because it's harmless or helpful in the situations it applies to, but it could be harmful or at best non-helpful in situations that it doesn't apply to. So I think that's an important part of this also, is understanding that systems are systems and they work for the things they're meant to work for, but they're not going to work for everything. And funny we talk about doctors of spine, because this is what chiropractic school taught me more than anything. It's not that there's a system that has the right answer for everything, but it's more so interpreting what a system does and when it applies and the principles that make it true to that application. So if you can look at, I don't know, McGill's Big Three, or you can look at, I don't know any of these systems because
McKenzie is one of them. I remember DNS, they're crawling around a fucking hotel lobby. A lot of chiros are into that.
So the reason that these things are prevalent and they exist.
Some are so dumb. Literally, I had to make a comparison to DNS. I was talking to some chiro kids and they're like heavy into DNS. And I was like, hey, do me a favor.
Were they bitches?
No, well, kind of, yeah. And again, I don't want to throw shade, but like, I literally, it's like, yeah, but like, it feels good after. I was like, yeah, I'm sure jerking off with a belt around your neck also feels good, but next time you do that, just put a mirror in front of yourself when you do it. Because if you
look yourself in the eyes.
Right. Like, at a certain point, like, if you put a mirror on the floor when you're doing it, dog, what are we doing here? And again, there's no way to say no offense and also say that and mean both of them. But like, like at a certain point, like put a mirror in front of yourself when you're doing this and be like, it feels good. It's like, what are you doing?
Yeah,
one of my favorite quotes of all time is by a British statistician. His name is, I swear this has something to do with what you're talking about. His name is George Box, which is like a hilarious name. And the quote goes, all models are wrong, but some are useful.
Okay. Yeah.
It's fucking brilliant.
And that's exactly the point that I was getting at as these chiropractic students are jerking off with a belt around their neck. I hate the world that we live in. But what I'm saying is that if you can look at these and not listen to what they're saying, but distill it down to why it works in that situation, then that's the value of the system, right? That gives you a tool that you can use to solve a problem. It doesn't give you the answer to all the problems. But if I can understand why Q12 Chiro kid's jerking off with a belt around his neck, then next time I have that problem, I can shoot myself in the face. But because that's the answer. But if I understand, okay, McGill's Big Three, really what we're doing is it's graded exposure to plane specific anti-movement through the core. Sick. All right, I'm learning to resist movement through all three planes through the core. And I'm doing so in a way where maybe I'm not dealing with the axial compression of gravity. Sick. That's useful. That's useful to know that. It's not useful to start to put dumbbells in people's hands while they're doing bird dogs on a bench and shit like that. It's if you understand the mechanism in which this is causing change, then you can scale that stimulus as opposed to understanding the method in which they're creating change and then scaling the method, right? It's not bird dog better, it's anti-rotate better. And that's what I'm getting at. Is these systems, they're not complete. And they're a very small snapshot of what will work in specific scenarios. But if you can understand why they're working and the scenarios they're working for, then that's the power that lies within those systems. So yes, there is value in learning these things, but not learning these things to a T. There's the value is interpreting these things and reading between the lines and not getting sold on, Mackenzie whatever, or jerk off with a belt around your neck chiropractic kid. Don't do that. Understand the principles behind it, and that's what's going to be the thing that allows you to apply that and cross-apply that to not just someone with low back pain, but maybe someone in the NFL offseason that's having trouble stabilizing their pelvis or changing direction. That's what allows you to cross-apply these things, is understanding the root of what's causing change and the specific change that's meant to create.
I think the biggest issue, and I feel like we're taking a dig at Chiros, but it's because it's so easy.
Oh, we are.
Okay, listen up.
There are people. We can do this.
Well, I think
right.
the thing that makes it, that's what that feels like. Okay, these are our words. Okay, all right. We lost Jay there for a second. I think what makes Chiros an easy group to pick on is the forced nature by which they are subjected to a fundamental method that goes ill-defined, and they are told to believe it from the jump, and the entire ethos is built around that, which is like, I adjust the spine and then things happen. It's like, okay, that is your core principle. If you learn to question it, it's a very freeing thing that allows you to go on the hunt for mechanisms. But if you accept that outrightly, which is one of the problems that I'll dig to fundamentally in someone's metacognition, how is it that you actually think, right? Empirically, what is the like epistemologically and ontologically, like how is it that you arrive at decisions? And for me, when I deal with Chiro kids, it's like, tell me about adjusting people's spines. And if I can tell really quickly about someone's ability to think mechanistically, if they have this unwavering adoption of this meta principle without ever understanding what the actual mechanism is. And like chiros are bad for that because the entire profession is built on it. Just like you said about the bird dog, though, doesn't mean we should like do away with like adjusting people's spines or whatever wholeheartedly. It's just there's a mechanism in there that's gone unfounded, and if you don't base your way of thinking, at its core level with curiosity, and you don't actually dig for the mechanisms in that thing, then you're unlikely to be able to think critically through other systems of thinking and ascribe just solely to the surface level system itself, right? And so if you're a Chiro student and you get asked the question like, okay, like what does adjusting do? And you put a fedora on and you start talking about like innate shit, you're like, no, homie, you're not listening to me, sir. Like, okay, sit down, tell me like mechanistically, what is the mechanism of correction? And if you can't have or even have a thought and it's just accepting it blindly, then I know you're not willing or you're not able to start to accept that, look, systems should be vehicles to start to communicate the spaces in between, right? The systems are waves where you hope to, in the wave going out and coming in simultaneously, to notice some sort of universal truth that you take that moment out, right? And, unfortunately, they're so prevalent because people's inability to think critically. So to me, Chiro students are so easy to pick on because there's an overarching story that needs to be dissected, and until you can accept with a certain ounce of humility the unknown aspects of what hasn't yet been discovered, but dig into and find mechanistically where there might be some room for inquisition, then you can't accept other principle, or you can't extract other mechanisms out of systems moving past that. So like if you're a Chiro kid, like have like a real think about what it is the fuck you're doing when it comes to the thing that you paid a lot of money to do. And then once you break free of that structure, you've kind of licensed yourself the ability to start questioning everything. And I wasn't like you said earlier, you got out of school and you didn't really know how to deal with low back pain. It's like, yeah, fuck, dude, it's the exact same. We sat pretty much next to each other for 4 years. And I think one of the best things that happened to me, and you're still amongst this, is working where we work in the Silicon Valley and like the tech hub capital of the world. Mechanisms drive that entire industry. Tech is nothing but understanding mechanisms.
Right.
And so when people come into our office, they were inquisitive in the way that they're inquisitive about their job. And like I was like, fuck. Like I actually don't know. I know these systems and I know these procedures, but I don't actually know the mechanism. So if you set your horizon, it's a fucking scary little horizon to set your sights on. But you learn some of the more intangible properties of being, a half-decent practitioner along the way, because you got to accept, like, yeah, dude, this is rough terrain. This is not a clear path, right? I'm Samwise Gamgee to this Bilbo Baggins over here. We're trying to sort this shit out. And that's like kind of what it is. And then maybe, after a while you turn into, I'm going to go full Lord of the Rings reference, you turn into a Gandalf, but it's still rough terrain. Like it's never going to be, and as long as you're not treating robots, like it's never going to be cut and dry, and you just have to accept it. And if you're a Chiro student, like question, at least don't question everything. Question that one thing first, and it'll allow you the ability to start to question things that need to be questioned. Anyways, I'm going to stop rambling on that. Sorry, Chiro kids, but when I say it's rough, it's going to be rough. You're going to start a podcast, start a successful business, and still contemplate killing yourself on the podcast 10 years later. So, and that's the best case scenario.
Hands down, the best case scenario. I like that, though. I like the idea of just being a skeptic, because that's what I've always been. And that was actually really discouraging while going through school when I started to peel back the layers, be like, yeah, those people don't know what the fuck they're talking about. And it's that moment that it's overwhelming, but it's kind of freeing in knowing that, like, all right, no one really knows, but I'm going to make this exactly what I want it to be. And that's the freedom, that's the responsibility that you have if you're in that position. That's what led, me definitely, I won't speak for you, but I think I can when I say that's what led us right here to contemplating suicide on this podcast
our life,
a decade later.
Yeah. And
But
look, go.
I don't know, I was just going to say, but just being skeptical, but do it in a constructive way. Not just to cause problems, not just to cause issues, not just because you're pissed off at the world because you're a chiropractic student, but do it to seek out those truths and find those answers and use that to create what you deem to be the best practices or something that aligns with your values in the way that you're going to practice. Because I can't define that for anyone besides myself. And that's exactly what I've used my skepticism to do. And I wouldn't rather be doing anything other than this, as skeptical as I am about my own life right now.
Yeah, I mean, when you think about it, like, Michelangelo is a skeptic, right? But so was, you know who Timothy McVeigh is?
I know the name. I don't know where I know it from, though.
Oklahoma City bombing.
Yes. Okay.
Right. Okay. So both of them, in essence, are skeptics. Now, what I mean by this, and I think it's an analogy to your point, because skepticism, by its nature, is tearing down things that are. It's not a creative endeavor, right? It is a destructive endeavor. There's something in front of someone has built something. In this case, we're talking about a system, and brought it to you. And you say, nay, I'm going to start to tear this apart. So skeptics can be really annoying if they're Timothy McVeighs. Because some people are but some people are eternally skeptical. And they look to tear down everything to nothing. And that's the ends to their means, is they're trying to just blow the face off this fucking building with a fertilizer bomb in the van in the basement, right? So, like, I agree with you that you're a skeptic, but Michelangelo also a skeptic. If you think about Michelangelo, the David, if you've ever seen it in person, this is massive, and you could put Bernini in the mix as well. It's like sculptors, by the nature, are, at essence of the analogy, a skeptic. They're trying to tear something down. It was a massive thing of marble. David was a massive thing of marble, and he went in there and he carved it, but he carved it to an end. In this marble existed this statue. He just had to whittle away and make this thing that is now sort of eternally the pinnacle of art, right? You up there, Mona Lisa, Starry Night, Michelangelo's David, like these things. But what I like about the sculpture is it started as something more than what it was, right? Van Gogh sat there and made something. He built onto a thing that was more. This is less. When you're being skeptical, and it's so easy to be skeptical and angry and be Timothy McVeigh or the fucking Columbine kids or whatever, and like skepticism when you're Timothy McVeigh is actually a sign, and it's not me saying this is like a sign of like low intelligence. People think they sound smart when they're skeptical and like, oh no, actually like, that's not the case. I don't want to bring in conspiracy theorists and shit like that, but people who are hyper skeptical of everything, to the ends of like the Oklahoma City bombing, they just want to tear everything down and they think everyone's stupid, it's actually a sign of low intelligence. But skepticism can be healthy if you're trying to whittle down something that's eternal, that's like Michelangelo's David. So it's like when you go through this process, and look, I've been on like I'm going to blow up the van. Like I've been, and it's just like, hopefully you outgrow that, because that level of skepticism you're not left with anything. And then you're just an angry person who's not good at what their job is. So it's like skepticism to an end, to a means of like, let's create with skepticism. And skepticism, but as a vehicle, technically, if you think about the relationship of what you're doing to ideas, it's reducing, it's breaking things down, it's negative in its action, but it can be positive in its outcome. So when you're skeptical about shit, it's good. And I know a lot of people listening to this, by the nature of the way we are skeptical. right? Like we're not a top 10 fucking whatever Apple podcast. We do well for the ratings, but I think we only do well because we reach people who are not accepting of the norm. But be careful, because I don't want you guys blowing up vans full of fertilizer. Don't be left with nothing. Be skeptical to an end that's something that is pristine. That's where skepticism becomes healthy and positive. That was beautiful. This is actually not water. It's just 40 proof. I'm fucking blast. I'm like Jim Leahy. I'm just smashed. No.
Just blacks out and spits bars on skepticism.
But it's true, though. Like, it bothers me because I know we're inflammatory because we talk in hour-long increments, almost to a T. It's hit the hour mark right now. And we put it on the internet, and we've been doing it for years. And, you know, I don't try not to abide by, like, the inflammatory bullshit. Someone calls me out, or I don't try and fucking... But it's like, I know when you meet people in person, like, oh, fuck, like, this is like an anti-thinker. Like, this person is like, man, yeah, I fuck with your stuff, dude. I'm like, yeah, okay, but why? You sound like you're trying to tear everything down. Don't do that. Because the thing is, I think we attract people who are, at least think about how they think, but be careful of that. Be careful, because you don't want to be in the van in the basement blowing the face off a building. You want to use criticism or skepticism as a tool to actually create, not to destruct. And it's difficult, and it makes you sound stupid when you're the opposite. And you know why I know? Because I put a mirror up in front of a guy with a belter. No, I'm just kidding. Let's end on that note. But skepticism is a tool to be constructive, not destructive, even though it's destructive by nature.
Love
there we
it.
go. A little bit of philosophy to close off the day here. If anyone's still listening, opt-in list for PSL 1, currently live. If you want to learn more about low back end philosophy, it's probably in there. I don't know. We do the new semester. Every semester is a new semester. Let's just say that. So we teach it live for the purpose of not, casting ourselves into antiquity and just being boring and out of date. So PSL 116 week applied biomechanics functional anatomy course starts September 29th. The only chance to save is joining the opt-in list. So if you head on over to www.pre-script.com, go to the PSL 1 page. It'll tell you everything you need to know about the course. Like I said, it starts September 30th, 29th? Whatever that Monday is.
29th, I believe.
29th. Lectures will start on that day. Labs will start that week as well. I think we're on 7 labs a week. Don't quote me on that, but we're 6 or 7 labs a week. So that'll take us right through into the new year. If you have any questions, reach out to us. Like I said, opt-in list, only chance to save. Head on over now, and we'll see you in class then. Any closing notes before we wrap it?
Thanks for listening, guys.
Always. That's all we can ask for.
I appreciate
Still
you.
here. Cheers.
I'm sorry.